Afternoon, everyone from many parts of the globe. My name is Mark Mendelson, and I am the Chief Executive Officer of the Canadian Associates of Ben-Gurion University. Once again, it is my pleasure to welcome you all to another Webinar Wednesday, which have become so popular with huge demands for more. I have to tell you that we have had more than 225 people registered for today's webinar, which just shows how important it is and how people value our two participants, our two experts. Before we launch into today's topic, I wanted to mention that our next Webinar Wednesdays event will be held on December the 8th at noon, Montreal, Toronto time. It will feature Professor Yaron Ziv, head of BGU's School of Sustainability and Climate Change, Israel's first school of its kind. You can already register for this webinar by heading to our website, www.bengurion.ca. And once again, starting in January, backed by huge popular demand, will be part 2 in our Israeli literary series, in conversation with Israeli authors. With only barely 50 tickets out of 200 remaining, we have sold over 150. I urge those of you who are interested to register already. The presenting sponsor of the event is once again Indigo Books and Music. The event sponsor is the Gerald Schwartz and Heather Reisman Foundation. And thanks to the Israeli Author Speaker Series sponsor, the Asper Foundation from Winnipeg, along with Donini Chocolate as a second event sponsor, you guys will have a lovely gift basket of goodies and swag. You have to be registered, though. It is very fitting that I've only just returned from 4 weeks in Israel 2 days ago and have become a quasi-expert on how to deal with COVID in the streets of Israel and in the airports of both Canada and Israel. Masks and proof of vaccinations are de rigueur, are the name of the game, whether to be allowed onto the Ben-Gurion University campus or just sit inside a restaurant or a hotel. The government's official proof of vaccines are a must, as are PCR tests and antigen tests conducted 48 hours before a flight. I visited the campus of Ben-Gurion 6 times, and I can tell you that no one is allowed onto the premises without their official government green tag, as it is called in Israel, or an immediate antigen PCR test at the point of entry. Not only is a campus full of student activity, and there's the usual BGU buzz all around, I also managed to film 5 or 6 reels, as I am told they are called today, short 30-second or so live reports from the campus. I felt like an international correspondent. But the country has emerged from the fourth phase of COVID with a vengeance. Montreal Board President Jack Altman and his lovely wife Diane, along with me and my wife Edna, had a private visit to the newly constructed and finished 1,000 dorm units on the North Campus. This is the part of Ben-Gurion University that will actually double the size of the entire campus. And the bulldozers are everywhere, moving earth in preparation for this vital expansion of BGU in order to be prepared to accept up to 5,000 new students within the next 5 to 10 years. So everyone is asking, what's now? What's the future with COVID vaccinations, quarantines, etc.? I am so proud that we have 2 of the top experts in the field with us today from Canada and from Israel to give us some answers. And the question is, the third vaccine and beyond, what goes? The format of today's webinar will start with my introducing both of the doctors, then each will have 12 to 15 minutes to address you all. I will give them a 2-minute warning. And then Galit Solomon, our Director of Communications and Marketing, will once again become the moderator in an outstandingly professional manner. Professor Nadav Davidovich, who I just met on the BGU campus in an Aroma coffee restaurant, is an epidemiologist as well as a director of the School of Public Health at Ben-Gurion University. A senior advisor to important public health organizations around the globe, Nadav has become one of the most familiar faces to the Israeli public, being constantly called upon by the government as well as all the news media to provide a deep insight and professional perspective on the pandemic and how best to deal with it in Israel. I must say, he probably has to walk around with his makeup already on. He's so often featured on Israeli TV. He's also become a personal friend. And a very short toda rabah, and thank you very much to Dr. Keith Meloff, who strongly suggested that we ask Dr. Pecos to participate today and assured his taking part. Dr. Barry Pecos is a person known to all people of Ontario, a public health specialist physician based in Toronto. But he is a graduate of McGill, Harvard, and U of T as well, as having completed a doctorate in public health ethics. He is currently in York Region and is leading many elements of the Ontario response to COVID. He is a program director of the Public Health and Preventative Medicine Residency Program at the U of T Med School and has worked extensively with the World Health Organization, as well as being Deputy Chief Medical Officer in Nunavut. Another wow of a CV. We begin with Nadav. Professor Davidovich, the screen is all yours.
Thank you so much, Mark. It's a bit of a surreal experience to just met you just a while ago, and now we are both on Zoom. And thank you for inviting me again. And it's a great pleasure to be on the same panel with Dr. Barry Pecos. We are close friends. We know each other for many years, including our shared interest in public health ethics. So what I'd like to do now is to share with you the current situation of COVID in Israel. We have the dashboard here. So as you can see, we have now 0.72% positive tests daily basis. And, you know, we were maybe in certain population higher than 10%, not so far ago. We have now more than 6 million with the first dose, 5.7 2 doses, and more than 4 million with the third dose that I'll speak in a moment. But you can see here, and I think this is telling us the whole, you know, story. See the blue rate. This is per 100,000 population. These are severe cases that are among those who are not vaccinated. You can see here the lighter green, those who are with 2 doses, and those who are vaccinated fully, either 2 doses less than 6 months or 3 doses. And I think this is telling us the whole story. Another thing that is very interesting, the last month, most of cases, positive cases, are among children. And I'm going to return to that because next week we're going to start our vaccination campaign for children. I have 2 grandchildren. Amit is going to be 5 just in 2 weeks. And Sahar is 6.5, and we'll be very happy to have them vaccinated. And actually, in contrast to what is presented in the media, between 50% to 2/3 of parents are very eager to vaccinate their children. We had lots of discussion. We saw the data from Pfizer and can assure you that the side effects are very low. We need to remember that the dosage is 1/3 than the regular one. And children, of course, are less sick than adults, but still, we had about 500 children hospitalized. We had about 150 with PIMS. This is after several weeks. It can happen even with asymptomatic children. And we know that long COVID is also relevant for children. So this is an excellent solution for on the personal level and also reducing transmission. So also from the community and solidarity perspective. Here you can see the rates according to different age groups. So you can see that, of course, among the elderly, vaccination rates are very high. With children, the situation is different. And another thing that we need to remember that there is a socioeconomic gradient. And I think that's something very important to mention. Of course, the virus has no intention, to infect this person or that person. But we know for sure that infection rates, severity, death rates all are related to socioeconomic status in Israel and in other countries. And within Israel, unfortunately, like in other countries, vaccination rates are higher among high socioeconomic groups. We are investing with the Ministry of Health lots of energies about that, including with the Arab Medical Association. Maybe you don't know, but in Israel, we have now about 700 Bedouin physicians, including women, and they are helping us quite a lot. Today, I was interviewed in Kikar Shabbat. It's a ultra-Orthodox, more Sephardic station, and we're working also with the rabbis and other religious leaders, and I think this is something very important to mention. Here you can see all different villages, and you can get the indicators that are based on how many active patients, the rate of third dose, second dose, first dose, and you can see where you are, and there is a gradient according to socioeconomic status. See here the number of severe patients. This is last month. I can show you here the last 3 months, and you can see the sharp reduction. And of course, the main explanation actually is the third dose. I'm calling it third dose and not booster, because probably it's quite evident right now that this is the schedule that should be like hepatitis B or other vaccines. Here you can see the reduction of the severe cases, the daily new numbers. And I think altogether you can see here that the situation improved quite dramatically. So what are the main issues that we are dealing? I want to show you just a few slides. Just a second. Where I can share the screen here? Oh, here it is. I probably want to start here. And unfortunately, we are facing in Israel, as in other countries, the situation that is quite horrible. We have Israeli health officials, including myself, under serious threats. This is Dr. Sharon Alroey. She's now escorted by police. This is in a social media event when she was attacked. And this is actually my Facebook. This is Dr. Mengele. So I'm accused of being Dr. Mengele. And in Hebrew, it says here that I have so much blood on my hands that with the death vaccines, I killed more Israelis than in all Israeli war together and car accidents. So I'm not under the same pressure like Dr. Sharon Alroey, but I think that indeed we are crossing the line here. We're pushing for open discussions, and after we had such just about 2 weeks ago regarding child vaccination, the second discussion was already closed because people were afraid. And I think this is something that is very severe. Now, I'm doing lots of discussion with anti-vaxxers. I think it's important to have a dialogue. I'm against compulsion, enforcement. I was for the Green Pass, but the Green Pass is not about compulsion. It's about creating a public safe, a public space that is safe, and we give the alternatives of doing the tests. And of course, I'm totally against suggestions that maybe people that are not vaccinated should not be given priority for treatment. This is, I think, unethical. Like we're not changing priorities for people that are smoking or overweight. I think this is definitely a slippery slope. So again, I want to remind us that vaccines are amazing, but they cannot solve all of our problems. The social determinants of health, are working, and we have all the mental health consequences by closing schools and unemployment and many other things that, of course, vaccines alone cannot be just be the only solution. So vaccines are crucial, but we need a multi-layered approach, and this is what Israel is now trying to do. We are finishing our fourth wave. We have now several hundred cases per day. This is exactly the time when we can do contact tracing and all the genetic typing. And after the mistake we did after the third wave, we are not dismantling all of the structures. We continue to have them, including the Green Pass, even if it's adapted and much diluted than it was, using masks in closed places, as Mark said before. And also we have several desks working with the ultra-Orthodox community, Arab community. Everything will be there. We are strengthening now the public health care system. Clapping to the healthcare workers is not enough. We need to invest. And I'm happy to say that finally Israel has a new budget, and within it, the health budget is much improved, including for the periphery, including planning a new hospital in Beersheba, something that I'm working for many years, also behind the scene. And also to say that I was nominated to be the chair of the Strategic Commission on Reducing Health Inequalities for the coming decade by the Minister of Health, and we'll be working with Professor Michael Marmot. Maybe some of you know him. He was the commissioner of the social determinants of health for the WHO, president of the World Medical Association. So this is very exciting. And I think that currently, and probably Barry will agree, we need to use public health ethics and understand that clinical bioethics is not enough. Public health ethics is about the community, and there are many questions now, like the Green Pass I mentioned, child vaccination and other things that we need to use this kind of approach. And maybe just to show you the several things that we are discussing now, including a question of variants, and what about tourism? These are very important questions, and I think that we need to understand that the COVID is going to stay with us, and we need to be to learn to live with it, but not in a passive way, in a very active way. And we need to understand that this was a warning sign, because now we are discussing climate change. Yesterday I was in the parliament. There was a new committee on health and climate change, is going to be headed by Professor Alon-Tal, a former professor from Ben-Gurion University. And there also the question of health inequalities is very important. And I think the lessons from COVID-19 is that we're all in the same boat together, and we need to move from vaccine nationalism to vaccine internationalism. There are enough vaccines now that we can vaccinate everywhere. Of course, there'll be the question of vaccine hesitancy, and it's not just a question of access, but the current situation where patents and intellectual property is preventing us from moving forward, I think it's a big question that is going to stay with us, including for discussing climate change. So are we really back to normal? Here on the left, you can see medical students at Ben-Gurion University, year opening a concert. And these are important questions, how we need to move on. And we need to learn to live with the virus, with vaccination, with other measures. And you can see here that Israel was always, this is the second, third, and fourth wave, was kind of the situation in Israel was preceding situation in other countries. Unfortunately, we had very high rates of infection, but the vaccination campaign was really very important. I'm going to skip it in the sake of time. But this is, by the way, work I'm doing with the Taub Center. I'm chairing the health policy program. I replaced the late Professor Dov Chernichovsky. And you can see that there are so many questions we can ask ourselves about how COVID is going to change our world in terms of working from afar, teaching from afar, home care, many important questions that we're going to face in the future. And here's one of our papers that we published, already cited about 100 times, how we addressed actually vaccine hesitancy. And you can see there is no one. There is not one answer. There are many different communities, and the question of health inequalities is important. So mobile units are working with religious leaders. All the question of the Green Pass that was helping us as well. And again, in this time in Israel that rates are quite low, we need to continue and see how we are moving forward with the vaccination campaign, and not just working with the high socioeconomic groups. This is vaccination rates according to socioeconomic status, the red places that are highly infected, and the green one that are high socioeconomic. So that's something that is definitely going to stay with us. And just to finish, and here's a project I'm involved in with the European, the Association of Schools of Public Health in the European region, the idea that we need to work on social determinants. And I want to finish actually with this kind of a paper that we published. We need to move from vaccine nationalism to vaccine internationalism, and to see how we can create a much more equitable, coordinated global health governance. Thanks a lot.
Nadav, first of all, do you not sleep? You're chairing so many committees in Israel and on so many TVs and in so many kikals that it's can't keep up with you. I mean, but what a neches, what a prize you are from Ben-Gurion. And thank you so much for always saying yes to us when we ask you to participate.
Thank you.
And now your counterpart, Dr. Barry Pecos from Toronto. The screen, Barry, is all yours.
Great. Hello, everyone, and thank you so much for having me. You can see my screen and hear me? Someone give me a thumbs up, just so I don't... Okay, I'm going to assume that it's all good unless someone tells me. So thank you so much for having me. And
yes, we hear you. It's fine.
You hear me? Okay, terrific. It's just so wonderful, and I feel so horrible that we can't give Professor Davidovich more time. Certainly, we're friends. We know each other, and more importantly, that he makes me look smart because you know, as has been said, and I'm going to demonstrate as well. Israel's always been 2 to 4 months ahead of us, and so you know, if you connect with your Israeli colleagues, then you can actually look like you have a crystal ball when in fact you don't. So and also in the, you know, the connection on the social determinants of health and the ethics and health inequalities are things that frankly Canada and Israel can connect in ways that frankly is more difficult to connect with our closer neighbor in the US. So it's really terrific, all the work he's doing. So thank you so much for that. I'm gonna spend a few minutes reviewing our current situation in Ontario. And for most of you that, you know, 200 of you taking your time out of your day in the middle of the day to go to a COVID update, chances are most of you know some of this, but hopefully I'll provide some, you know, additional insights as well. I also want to share that I spent 4 years in Beersheba accompanying my wife, Brenda Weitzner, who's went to medical school there and is now a family doctor with a pediatric specialty here in Toronto. And if you go to Ben-Gurion in Soroka Hospital, you will notice non-smoking stickers with an Ontario logo, because I spent much of that 4 years fighting smoking informally in the hospital, as well as teaching at Ben-Gurion and Hebrew U and in Tel Aviv. And this is my first daughter, Shayna, in the halls of Soroka, where I just, you know, without any permission of any kind, just put up some poster and had some material on World No Tobacco Day. So lots of connections with Beersheba and Ben-Gurion. So what I'm going to do today, just for the 15 minutes that we have, just talk a little bit about where are we and relative to Israel as well, address a couple of the questions that were submitted and give a little bit of insight around the Toronto Jewish situation, and of course answer your questions at the end. And I'm going to speak quickly, so please slow me down if that's an issue. The big picture, Ontario, as I'm sure most of you know, we're in an upswing of a ripple of the 4th wave. Now we have 3.5 cases per 100,000, and even though Israel has declared, you know, COVID is over essentially, they still actually have twice the number of cases per 100,000. So in Ontario, as many of you know, we have a much lower threshold. So we never got anywhere near as high. And if you look at the comparative numbers there, Alberta is 2 or 3 times what we are in Ontario. You know, Michigan, our neighbor, is well over 10 times where we are right now, as is the rest of the US. And that's a very good thing. And our hospitalizations in ICU are stable. That's just a mini, I'm sure nobody can read that, but that's, you know, just to show that they have been stable through the 4th wave. We have vaccine certificates for most venues and masked indoors consistently for well over a year. We never got rid of those. And that's one of the reasons we've been so successful compared to, you know, places like Saskatchewan and Alberta. Our mobility, remains down about 10 to 30%, depending on what sector you're in, meaning the number of people who go to work, the number of people who go out for recreational purposes, although you wouldn't necessarily know it by the traffic in Toronto and Montreal potentially, but our mobility is still down, and we track that through cell phone data. And we have, vaccine coverage of 85% of those eligible, and the 5 to 11 vaccine campaign will start next week as well, just like Israel, or the week after probably. Nobody should quote me on that. But of course, we have different weather patterns. And so as we move indoors, and we have Christmas that they don't have in Israel, the Chagim in Israel were a more difficult time, as they were in the Jewish community in Toronto with COVID. But we tend to gather more. And so we're really hoping to keep it as low as possible with a view to that gathering that's going to be happening. So today's cases, as I'm sure many of you know, going up, but still steady and not that concerning unless you're in public health and in the response, which I am, which means that my staff is getting much more busy, particularly in schools. And there's the, over the past 3 months, what things look like. We had a big peak. We had a nice trough, and now unfortunately we're going up again, but hopefully not for long. Our daily cases, and this is just to compare Israel and Canada. As you can see, Canada and Israel in a similar place right now. And as Professor Davidovich already showed, Israel was far and above even the US. The US was far, far, far above Canada. Unfortunately, we've weathered things very well, including among cumulative cases. So still in Canada, and there's going to be some questions about herd immunity, still less than 5% of Canadians have had COVID, whereas about 15% of Israelis, and Professor Davidovich, correct me if I'm wrong here, but that's my understanding. So, very different picture overall. And of course, deaths have been different and much lower in Canada and the United States, much lower in Israel compared to the number of cases that it had. But Israel's been similar to Canada. And one of the reasons, of course, is we have very different population in Israel. In Canada, we are much older. Israel is much, much younger, which influences, their overall percentage of the population that's been vaccinated compared to the eligible group. And because there are so many younger people, as well as a better hospital capacity, they've had fewer deaths than others who've had a similar number of cases. This is, I think, a really important thing as an epidemiologist, public health specialist, looking at the population pyramid to understand a lot of the differences and trends. One question that gets asked, and before I go on to some other topics and some of the answers to your questions, can we booster ourselves out of the waves? Israel has done that, it seems. Other countries, and I'll give you the example of Austria, that's now in a nightmare scenario. Actually, for Israel is good because they've exceeded now the number of cases per million that Israel had topped out at previously, despite having a pretty good third vaccine campaign, not as good overall vaccination. But other countries are similarly challenged here, including Ireland, which has an exceptional doubly vaccinated case, similar to Canada's, about 75% of the entire population, and yet is really exploding with cases now. So we have to be really vigilant. Here's just the numbers. Of course, 88% of our eligible population, almost 9 out of 10 Ontarians has had at least one dose, which really, speaks to, the social cohesion piece, and the fact that we have crazy anti-vaxxers, also very aggressive and sending me emails and threats that are challenging at times, but still such a smaller proportion of the population than in some other countries. So I still am thankful to be a public health physician in Canada. Just to highlight a couple of trends. So for our 12 to 17-year-olds, as Professor Davidovich mentioned, Israel is around the 60% mark among the 12 to 15-year-olds, and we're closer to the 80% mark, at least with one dose there, and among the 17-year-olds already at 90%, which is really great and portends well for our 5 to 11 campaign. And we did that within about 90 days. So we don't go as quick as Israel does because we have very different infrastructure. We don't have a health system per se, and we could talk about that later on, but we managed to cobble it together and do a pretty good job, which is terrific. And we're hoping to get to 50% coverage in that group within 3 weeks. One of the things that I wanted to mention that is at the forefront of what we're doing now is about vaccine intention. So polling, a number of different polls on whether parents are going to vaccinate their kids. And as you see circled here is Ontario. We have about 75% of parents saying either, yes, I'll get my child vaccinated, which is almost over 50%, and another 20 say eventually they'll get them vaccinated and just waiting to see what other people do first, and that's perfectly reasonable. And only about 18% say they won't get it, and that is different in different provinces. If you see Alberta and Saskatchewan, a little more of a libertarian bent there, and closer to 30%, 25 to 30%. That's an Angus Reid poll, and here's a forum poll. It's great to have all kinds of different methods to triangulate this data. The forum poll said about 70% of parents intend to get their children vaccinated in Ontario, 19% unsure, and only 11% don't intend to do that at all. And about 80% of those who are going to get them vaccinated will do it, right away, which is terrific. And actually 2/3 of parents are in support of COVID-19 vaccine mandates for kids and childcare. So, we've got a lot of support for that. I don't think our government is, I know that our government is not keen on that and won't do that, but I think that bodes really well. We got a couple of questions, most of which Canadian oriented. So I'll try to answer them with a little bit of data behind them. I'll answer them quickly here on one slide and show you a bit of data as well. So can you speak about experience with AstraZeneca in Canada and the levels of protection with and without an mRNA booster? The bottom line is AstraZeneca was protective versus severe illness, hospitalization, and death, but the mRNA booster very much helps. And I'll show you the data on that. Ontario/Canada plans to vaccinate children. Hopefully we're good, as I mentioned there, but I'm happy to speak to that more if people have questions specifically. It seems 400 to 600 cases with fewer deaths is a tolerable threshold. Yes, it is tolerable, but it's more about trajectory. And as I mentioned, as we get into the winter break, we are going to see an increase as people gather. So we want to start that winter break and this season lower, and Hanukkah is coming early for us, and we want to be really lower than 400 to 500 cases if we can be, so that much lower end number in the start of the new year. And as people know, we've paused reopening. We were going to open strip clubs and a number of other venues, and unfortunately for everybody who's interested in those venues, they will not be opening. They're high-risk venues and will not be opening now. Will we be moving towards yearly COVID-19 vaccines? Unlikely, but it's certainly possible. So here's a slide of vaccine effectiveness. This is from the Institute for Clinical Evaluative Sciences. A good friend of mine, Jeff Kwong, graduated together from U of T at the program that I now lead. If you look at the last table there, the mixed schedule, AstraZeneca and mRNA, in the really small print there, around 100% to 93%, 95% in a variety of time frames in terms of protection against symptomatic infection. So, as you can see here, AstraZeneca Covishield didn't do terrific after a long period of time with just that vaccine, but with the mRNA booster, it does very well. So I think people can be confident that they are protected. And with respect to severe illness, the AstraZeneca vaccine still did very well, even 100 days, quite some time out, even out 110 days, even up to 3, 4, 5, 6 months later, did pretty well against severe illness or death. But with the extra booster of the mRNA vaccine, did even better. So I wouldn't be concerned for those who got that schedule. We do have some evidence of waning immunity, certainly, and there's lots of evidence from Israel. And in Canada and Ontario, what we have is the evidence that the longer interval between the doses seem to confer some additional protection. It's not totally clear yet because we don't have great data, all the way to 8 months with some of those groups. But it seems that the vaccine immunity, the vaccine effectiveness decreased with just the 2 doses in those that had a shorter time interval, and those that had a longer interval, it didn't decrease as much. But that's only against infection. With respect to severe infection or death or hospitalization, that immunity, regardless of your interval, was pretty good. So we have good data on that, and we're continuing to amass it. I think probably in the next month or 2 we'll have better data. So there's a lot of work being done in Ontario. It's a struggle to get our data. We don't have data systems anywhere near as good as Israel, but generally the vaccine effectiveness for the mRNA vaccines is still very good, excellent, I would say. But there is this sort of waning immunity against infection, but not severe outcomes. The intervals are associated. So, most of us.
2 minutes.
2 minutes, great. Okay, I will I will, a couple of notes on Israel versus Canada. Our response overall is proportional to our competence, our capacity, and our governance and social cohesion. That's where the social determinants of health certainly come in. Israel and Canada, very different, demographic and age structures, as I showed you. I wanted to show this slide again because while only 4% of Canadians had COVID, about 50 to 70% of Haredi Jews in Toronto, and that includes among kids. That's an approximation, but I think that's, it's at least 50%, I would say. So very much depends on what community you're actually in. And actually we collect race-based data in Ontario. Again, it's tough to get this data, but much higher in South Asian, Latino populations. They tend to be the PSW, the personal support workers. In the Black community was much higher. And in the Black Hat community, although we don't have good data because, one feature of our data collection is we don't collect based on religion, and certainly not based on subgroup within religion. But I know from a lot of the work that I've done that it is much, much dramatically higher. And one of the things we're trying to do is to get people engaged in the public health community in addressing that issue. And the reason for that is that we just get together more. So the average Ontarian has 12 close contacts in a week, and the average observant Jew has about 120. And there was some data, some work done in Belgium that actually, got that number there. But certainly, anecdotally, we do know that. This is actually a table from, last spring that showed, based on the amount of contact relative to normal, what kind of, next wave we're going to see. So if we get down to 70% of our current or decrease 70% of our contacts, then we're going to be able to level off. But if you're starting at 12 close contacts a week, getting 70% down means only 2 or 3. When you have in households, I have 5 children and many observant Jewish families have quite a few, your contacts cannot get that low. And so if you reduce it by 70%, you're well above the Ontario average. So that's the reason for that transmission density. So I spoke very fast there and happy to answer questions. So I see there are quite a few in the chat. So I'm ending 47 seconds early. So.
Wonderful, Dr. Pekas, thank you so much. And if Dr. Davidovich can join us as well on screen, that would be great. We're going to enter the question period of this this webinar, and we've got quite a few questions. We're hoping to get through as many of them as possible. I'd like to begin with a question that came to us from Dr. Keith Meloff. And of course, as Mark mentioned, Dr. Meloff is the one who helped us secure one of our speakers for today, Dr. Pekas. Thanks so much for that, Dr. Meloff. And here's the question: does Israel or Ontario conduct widespread immunologic surveillance, such as serum COVID antibody levels on both vaccinated and unvaccinated, including COVID recovered patients, to understand the duration and level of immunity in these populations, vaccine efficacy, and the level of herd immunity? And this question is directed to both of you. Perhaps we can begin with Dr. Davidovich and have your answer first.
So the short answer is yes. We're doing that. Actually, there are several such studies. The Ministry of Health is doing a population-based study, Clalit Health Services, also Maccabi Health Services. And there are also studies that are done on healthcare workers. For example, in Sheba, many of these studies were published in, places like Lancet, New England, and the whole decision to do the third dose actually was based on these studies. Now, the thing is that things are so dynamic that sometimes it's really hard to, when we started to have those discussions by late July, early August, it was not exactly clear the waning immunity. Is it just in the elderly? Is it related maybe to the Delta variant? And gradually, as things moved forward, we saw that the main issue is actually time that elapsed since the second dose, and we saw the waning immunity in all age groups. Now, I think what is really great in Israel that these are not just immunological studies, but a combination of both immunological, clinical, and epidemiological. Because the fact that you see reduction in antibodies is not necessarily saying that people are not protected, because you have cell immunity, things are more complicated. In general, I would say that, and it's related to what Barry was showing us before, it seems that the third dose is lasting longer, but we need to be very humble. So many times COVID made us strange surprises. So for now, it seems that the third dose is, getting us longer. And of course, there's a question of the interval between the first and second dose. We're going to have on Sunday an expert a discussion on vaccinating children. Maybe there'll be a decision to have an interval longer than 3 weeks.
Right.
And this is a very interesting question, of course.
And quite a few questions actually about children as well. But let's get a Canadian perspective on that initial question, Dr. Pekis.
Sure, I'll answer the very last thing that Nadav said. So we are going with an 8-week interval for children. And you can get it earlier if you want, but we're going for 8 weeks, just so you can take that back as to that committee, just in case they weren't aware of what we're doing. But are we testing for antibodies in the population? And yes, we are in Ontario, in Canada. We're doing that kind of not in as systematic Ontario to link that lab result with the clinical course that a person has had. And in Israel, they can do that rather seamlessly. We can do it. It's just sort of like a stretch, right? So, we know, for example, in Canada that 4% number or 4.5% of people who've had COVID is probably about right. So all these people saying like, oh no, really 15% of the population's had it. If you're in the religious Jewish community, many people feel that way because everybody they know has had it, but actually only still 4 or 5%, maybe up to 6% of Canadians have had COVID. So that's pretty accurate. And of course, when you're asking, are we tracking antibodies? It's, antibodies to infection are different than antibodies to the vaccine. And we are not doing a very good job in a systematic way or on a population level of looking at antibodies to vaccine. But we know that others are. So that's the answer, essentially, that question. The answer is yes, but with some caveats. And we do have longer cook times, let's say, for things to get published in Canada. So I know about them because, my colleagues in public health, get them to our decision makers, but it takes a bit longer to reach the broader community. And there's a culture in Israel of publishing things. The publisher parish push is much more acute, which is good and bad. Yes.
All right. Thank you both for your answers there. The next question comes to us from Mel Schloss. And the question is, do you have any thoughts on Canada discontinuing the need for a PCR test when returning from the US to Canada? And I guess that question will go to Dr. Pekis.
Yeah, but I'd be interested to hear Professor Davidovich's approach as well. But there are political discussions. So I think it's important to recognize, and this is the same in Israel, I presume, that there are decisions that are impacted by the public health leadership. And then that goes to the cabinet table in Ontario, or the cabinet table federally. And we never know what's going to come out of that cabinet table. So as far as I know, there hasn't been any direction to do that. And lots of people are upset about that. The reality is what we have seen in Canada is that the rapid tests are, to use a word, crap. and they are, because they're self-administered most of the time, they are very difficult to keep track of. And at a border where that sort of objectivity of a lab result, as forgeable as it potentially is really important right now. So I hope it doesn't change for the holiday season now, until we get the kids' vaccinations done, and then the boosters. It very well might even sooner, depending again on cabinet. But my public health advice and our public health advice collectively in Ontario to influence the federal decisions has been not to change that until we're over that hump. As difficult and as expensive it is. I know, having traveled from the US with 7 people, 5 kids in camp, it's $1,000, $1,500. But I think it is very important to prevent importations. Again, unlike Israel, we have a border with millions of people from the United States, still a global epicenter coming across. All theoretically have been vaccinated. Many have not actually been vaccinated as they come over.
Okay. And Dr. Davidovich, did you want to add to that?
Yeah. First of all, these, scientific advisory committees giving advice to politicians. It's a study we are doing now. Barry, you know Professor Maria Ellen, so we are doing it together.
Oh, really?
She's a graduate from the University of Toronto, a professor at Ben-Gurion University. In Israel, there was, and I won't convey my personal opinion, but there was just a decision made yesterday that people returning from abroad, before returning, they can do either this is a change, either PCR or antigen test. Antigen can be done 24 hours before, not the home test, but from laboratories. And of course, there are the problems that Barry mentioned. But when landing in Israel, you need to do the PCR, and this is a kind of a compromise. So you can still, you have the PCR when landing, and you need to be on quarantine until you get the results. And this PCR can be used also to do genetic typing if needed.
Okay. Moving on, a question from Eric Grove, who asks, for those of us who are immunosuppressed, transplant recipients who have been tested and have low or no production of antibodies following serological tests, even after the third dose, will this prove to be an impediment to entry into Israel? So Dr. Davidovich, maybe we can begin with you there.
So if people are vaccinated 3 times, they're not going to be tested for, I'm talking now about the bureaucracy. It's not, some kind of medical advice. I'm not sure for such person, this is the right time to travel abroad, but sometimes it's a personal decision. You have family matters or other matters. So if you are vaccinated 3 times, you can come to Israel. Nobody will ask you if you are immunocompromised or what is your antibody level.
Okay. And Dr. Pecos, we have an anonymous question here, just in regards to a strain that has popped up in British Columbia. I'm just looking for it. There it is. A new variant has just been discovered in BC, AY.4.2. I'm not sure whether I'm saying correctly, which has people concerned again. Is this the new reality, one new variant after another?
Yes and no. Yes and no. I mean, yes, we need to worry about it in the public health community, and certainly AY.4.2 is, and I'm sure Professor Davidovich has similar comments on it. We're watching it carefully. It has the potential to be concerning. It is not competing well with Delta right now, but we're going to see how things go. That's where, one of the great things that we do in Canada, a little more than our friends in the States, is have some confidence in our public health leaders or our governments, not full, but not bad. And I think that's one of the areas I trust my colleagues. Hopefully they trust me as well. And when there is something we all need to be worried about, we're going to jump up and down and let people know. And it could be AY.4.2, but it doesn't seem to be right now. But we are going to be continuing to look at this. We're going to continue to hear about it. If there's a dramatic vaccine escape strain, then we're all going to hear about it and be very concerned. But we'll see how things go with respect to that. It's been around for quite some time internationally, that one.
You both addressed threats because of your, oh, sorry, go ahead.
No. I just thought Professor Davidovich would have an answer to that.
No, I totally agree. It was exactly, I have the same perspective. And part of the problem is until, we have this gap in vaccination rates around the globe, and this is a fertile ground for developing variants. This is part of the, disease ecology. So I think we are maybe less stressed because we know that there are going to be variants all the time. We just need to develop and invest in the genetic typing. And I want to say that on March 2020, we had the state comptroller report. I was testifying before of this committee, and this was about outbreak investigations in Israel. And it was clear that we didn't develop enough, although for years we are calling, to do genetic typing as part of epidemiological investigation. It's a crucial tool, not just for COVID, for antimicrobial resistance and many other things. And it's a shame that I think in Israel and in other countries, I think in Canada, the situation was much better before COVID regarding investing in this part, also in the UK. But at least in Israel, we had it, but at least we learned our lesson, and now we strengthen our laboratories to do the genetic typing. So this is a good investment, not just for COVID, but in general for public health.
Okay, thank you both for that. The question I was going to ask next was in regards to, and it comes to us anonymously as well, public health professionals have become celebrities around the world in many ways. I know you've both appeared on television, and Dr. Davidovich, you've appeared on television here in Canada as well. At times, the question asks, at times they have been accused of being too close to government and at times too critical. How do you manage this?
I've been engaged with public policy in the last 2 decades. I think that in general, we need to strengthen the public system. I think it's a responsibility of the state, and we need to help the state to, doing all the, if it's health, education, or other things. On the other hand, I can be also critical. We just had a meeting. I'm sitting on several committees, but I'm trying to be, as far as I can, impartial and raise my voice. Give you some examples. I was very critical when Israel was using the secret services to do the contact tracing. I think this crossed, Barry, I don't know what's your take on this, but I think it, both from, moral aspects and even utilitarian aspect, I think it was a very bad idea. I was also critical when, we got to lockdowns that I think could be prevented. Sometimes you have no choice. But lockdowns, for example, it's not like pressing a button. You need to prepare. You need to have all the social and economic aspects. So I think I'm trying to be, it's a thin line that I hope we can walk there. This is why finally I choose to be, I worked in the Ministry of Health and finally I decided to be in academia, but I'm still chairing committees with the Ministry of Health. So it's very tricky, and I think trust is crucial. So you need to be transparent, and you need to keep your kind of professional backbone. And there is no one answer. And it's also sometimes, your personal kind of temperament. Some of have a certain style. I can be critical, but at least smile and also try to talk with the government. And I don't try to be critical just to be critical. I'm trying to change, to make a change and to have a dialogue. By the way, also with people from, not from the government. And I think the role of academia, NGOs, civic society was crucial here, and in general for public health.
Yeah, so I mean, a similar answer in the sense that, first of all, I think it's so amusing that you would even think that we could use our Secret Service in Canada as if we have one to do that kind of thing. we just, isn't going to happen. And we have, we're just, it's basically an honor system for the most part in Ontario. Even when we see egregious things happening, public health is very limited in what we can do enforcement wise. Frustrates lots of people, let alone public health. But from a media perspective, one of the reasons that I am able to be on the media on a almost daily basis, for better or for worse, is the academic hat as well as the practice hat, which there aren't a lot of people who do that. And I feel like I am going to be taking on a new role shortly where I won't be able to do that as much anymore. But I think that's incredibly valuable. And I've, the key piece about criticizing government, and let me tell you, we are not in Ontario, in Canada generally, but in Ontario specifically, medical officers of health are totally independent, except that we rely for our funding on the government. And as many of you probably know, we had our funding cut by between 30 and 70% just before the pandemic, which made us very upset and reluctant to criticize government anymore because we were worried about it getting even worse. But we do that, and we can criticize within and without, but reserving that criticism when it's really necessary. For example, in my case, I was very critical when they did not reopen the schools at the end of last year, in last spring, when they really should have, and they didn't, and that didn't end well necessarily. In that only people above the age of 55, 60 watch television news. So I know my parents' friends are always watching there, and the younger people are not, but the politicians also are watching the news. And so you can count on being seen there. And so it is a fine line. But it's great to have that higher profile in the relationship with the media, which in the past has been much more of a tension with the media in public health than anyone. But right now, because they need us in the media, I can tell them something. I think you should, focus on this or focus on that, and they actually listen now somewhat, which is really nice.
I think too, with some of the notoriety, as you both mentioned, come threats, and you both mentioned that you experienced threats. Can you tell us about that experience and what it's done to you personally? Because at the end of the day, yes, you're health professionals, but you're also human beings, and we all are going through this experience together. You're the experts here. People are asking for your feedback, but on a personal note, what has that experience of receiving threats been like for you? Dr. Pecos, maybe we can start with you.
Sure. The threats by email are always more interesting, and I know that when I'm on a conservative radio show, I'm very likely to get much more, and I don't worry about them too much. The ones within the Jewish community are fun. About half of them are people bringing scotch or Shabbat meals, and the other half are threatening to picket my house. So it's on both sides, and occasionally when there has been a "I know where you live, watch out" kind of thing, fortunately, whether it be the police or other community members sort of came and said, like, that is definitely not okay. And it affects different people very differently. Certainly, as the program director of the residency program at the University of Toronto, my younger colleagues and trainees experience that very differently and have a different degree of fear around it. But it is certainly disconcerting, as well as sometimes entertaining, but mostly quite disconcerting when it seems that they're really serious.
Yeah, I'll bet. And Dr. Davidovich?
Maybe since I served in the military as an officer, being also on several Gaza wars and Lebanon, so maybe I take it in perspective. But I truly think that in the last few weeks, especially with children vaccination, it became very emotional. So many times it's even a bit amusing. Even the Dr. Mengele thing, so I'm collecting them. And Barry knows that I'm interested in the history of medicine. And we just got a grant about the shadow of the Holocaust on the development of bioethics in Israel and in Germany. So thinking about people comparing me to Dr. Mengele, it's a bit crazy. But I think that maybe people within the government, not just on advisory committees, but like the head of public health services, this is different. So she has people coming to her house with crazy demonstrations, and she has young kids. So I think this is totally unfair. And again, I'm having discussions, and I'm also sometimes going to strange bizarre radio stations, and I think it's important, but sometimes this is really crossing the line, and maybe even we should be more, we have better enforcement, I guess. But I think both in Canada and in Israel, finally, we are lucky that it seems that the vaccination and public health, with all the problems, are much more kind of accepted and maybe mainstream. You know, even comparing to countries like France or certain places in the US. Yeah.
We're going to just go back to a medical question now. After 2 Pfizer vaccines, this is coming to us, by the way, from Farla Cohen. After 2 Pfizer vaccines, is it okay to get Moderna for the 3rd booster?
So I think Barry was showing some of the data that was hinting yes. So the answer is yes.
Yeah.
And there's already quite lots of information. Sometimes we have people that got severe allergies from messenger RNA, and then they can get AstraZeneca
or Johnson & Johnson. We just imported a little bit of Johnson & Johnson for those people as well.
Right.
Oh, sorry, go ahead.
No, this whole question of mixing became very important. And by the way, it's not unique to COVID. I mean, there are other, I remember in the past, you know, hepatitis A, hepatitis B, you know, mixing, but here we have different technologies. So we can now say that that there shouldn't be any, it's not a big issue right now. People can be safe.
There's another related question, and Dr. Pecos, maybe you can take this before we say goodbye. This comes to us from Bernard Katz, who asks, what cautions, if any, should be taken regarding having this year's flu vaccine in combination with the COVID vaccine?
So in Canada, we are advising co-administration and in theory, waiting 4 weeks in between, but in practice, I wouldn't hesitate. Whenever either one of those vaccines comes up that you can get it, you should get it. We're advising among the children's vaccines not to, you know, only have one vaccine within 2 weeks of another, mostly so that we know if you're having a reaction to one or the other. But to be honest, in practice, you know, there's all kinds of guidance and recommendations. In practice, you know, I really wouldn't hesitate. There's no evidence of harm there, and there's no reason to suspect that you wouldn't mount a reaction to it. But strictly speaking, we usually like to separate them.
Okay.
I totally agree.
Yeah. Okay.
I'll thank you both. I see Mark is back on the screen, so I'll hand it back to Mark.
Okay.
Fascinating. Do you know that we still have 21 more questions? I don't think we've had another webinar with so many questions which have been answered and which have remained unanswered. Now, if I promise each of you a falafel, maybe you'll stay on for another couple of hours and you can answer the rest of the questions. But
I'll do
Dr.
it.
Barry and Professor Nadav.
Maybe, Mark, maybe knafe. Knafe, it's better.
Ah, I had good knafe and kalanswa.
Oh, nice.
Oh yeah, with the, anyways. Galit, Nadav, and Barry, Hamon Todot, fabulous webinar. Another outstanding one organized by our CABGU team, which by far is the best Israeli-based organization team in Canada. These webinars have attained us a very positive and huge following of quite a few thousand of new participants. Once again, I urge you all to stay tuned for our upcoming webinar on December the 8th, as well as our literary series. May I also take this opportunity to wish everyone Jewish on the call a very Chag Chanukah Sameach, it's just in a week time, and a Happy New Year to all, or a Happy Gregorian Calendar New Year to all, if you want to be precise. I will be visiting BGU again in just 2 weeks, believe it or not, accompanying a very important and transformational donor. Can't wait. All the best for now. Thank you all. Thank you, Barry. Thank you, Nadav. Thank you, Galit. And thank you, CABGU team. And thank you all for your 225 people who have been on the call. Mark, over and out.